Uh, Um, I'm also, I don't know if everybody saw that, but you should all know that we are recording this to play it again for others who are not able to join us today. We surely hope that you are getting through what has become our new reality, as all of us are trying to transition ourselves back to being live or some sort of hybrid. And we are looking forward to when we can start doing a lot more live events, which will be upcoming. Some have started already, some will continue. And we urge that you go to diabetesresearch.org and find out what exactly is going on around the Institute, around the foundation. And we are certainly glad that you can be here with us now. When Dr. Baer is done with her presentation, we will have a question and answer time. So I'd ask if you have any questions to just jot them down, and you can ask her when she's done giving her presentation. I was talking to somebody this week and they said, Tom, you've been at this a long time. I have 2 kids with type 1 diabetes, as well as being a staff member here at the foundation. And they said, why the Institute? And if you've ever done anything or worked with anybody in the diabetes world, people come, people go, things change, things move on, people do things, people don't do things. The focus of the Institute has never changed in all these years, to find a biological cure for this disease. So for me, that's what I want for my kids. It's easy to say, oh, it's too hard, we're not going to get there. But to constantly go back into that building every day, our scientists go to work every day with but one objective: to cure this disease biologically, to make it last forever. Not as easy as we thought it was going to be in the beginning, but it's a constant in our lives that we are going to stay at it till we get there. And with that, I'm more than pleased, I'm honored to introduce our presenter for this evening. And that's Dr. Allison Baer, who's a PhD and is a research assistant professor in the Department of Microbiology and Immunology at the DRI, the University of Miami Miller School of Medicine. Dr. Baer's research focuses on understanding the basic immunobiological of regulatory T cells and applying that knowledge for future clinical translation applications. She's going to explain what that means. She hopes that her work will lead to the design of novel therapies for a non-toxic approach to tolerance induction, with the ultimate goal of achieving both self-tolerance and transplantation tolerance for the treatment of type 1 diabetes patients. Now, I'm going to ask her to also translate what all that means too. So we are super privileged and honored. And Dr. Baer, we welcome you, and the floor is now yours.
Thank you so much. I'm going to share my slides. Does everybody see my slides? Perfect. Yep. So hopefully by the end of my 20 minutes or so, you'll understand all those big words that Tom just said. But thank you for that wonderful introduction. And thank you everybody for joining us tonight from wherever you're joining us from tonight. Everyone that works at the foundation knows I love walking into the building every single day and getting an opportunity to gain knowledge and really have an impact for patients that are living with diabetes. It really is, as Tom said, we all work for a common goal when we walk through those doors every day. So really, I'm a cellular immunologist. So what is a cellular immunologist? It means I study the cells of the immune system. So I like people to think about their immune system as their own private army. So you have soldiers that do different jobs. So when we're thinking about an immune response, you have some type of danger. It could be a bacteria, it could be a virus. You get a skin break and you get an infection. So the first wave of soldiers that come in are called these effector immune cells. And their job really is to destroy the danger. And because that pathogen doesn't belong to us. But more importantly, we have a second wave of soldiers that come in, and those are called regulatory cells. And they tell the soldiers that are doing all the destroying that the danger's gone, everything's okay, and move on. And that second wave of soldiers that come in is really important for initiating tissue repair. So that's an important element when we want to think about autoimmune diseases. And the other type of soldiers we have, we call tissue resident cells. So those cells are the ones that sound the alarm. They're the ones that see the danger. They say, hey, something's not right here, and we need you immune cells to come in and do your job. So my lab really has like 4 ongoing research projects, but today I'm just going to talk about regulatory T cells. So hopefully by the end, you'll understand what a regulatory T cell is. And then at the end, I'm going to talk a couple of slides about a fairly new project that we've had in the lab for about 18 months, studying a drug called dimethylfumarate. So those are going to be the 2 topics that we're going to talk about in the context of type 1 diabetes. So I know for this crowd, we don't have to go into too much detail about type 1 diabetes, but as most of you know, it's an autoimmune disease. So you have immune destruction of some type of cell within your body, which normally your immune system doesn't see yourself as dangerous. In fact, your immune system is designed to protect self. That's why you have these different types of soldiers that are very good at eliminating the danger. But in autoimmune settings like type 1 diabetes, something is not quite right, and the immune system starts to attack our own bodies. So in type 1 diabetes, it's the destruction of the insulin-producing beta cells, which are within the islets, which are within the pancreas. And you get this mediated immune destruction of these cells that are making the insulin. And so patients have to rely on lifelong insulin injections. So just so we're all in the same page when we're talking about a normal immune response. So there's kind of 4 stages we can think of immune response, and really we call it immune response inflammation. So you probably hear anti-inflammatories, especially with COVID. That inflammation was out there a lot, that word. So if you think about your healthy skin, we all have what we call commensal bacteria that sits on our skin. And so most of the time, those soldiers that I said are tissue resident, they're the ones that'll sound the alarm when the danger comes. These are these tissue residents that'll sit just below the surface of the skin. Of course, you have blood vessels. You've heard of red blood cells. Well, immune cells are called white blood cells. And these are constantly circulating throughout the body looking for danger signals. So think about when you get a scratch on your skin, you have some kind of wound. Now bacteria can get in to the lower layers of the skin, and you have these soldiers right here that are sensing this danger, and they're going to start causing an alarm to happen. And you have this influx of these effector cells, the ones that are going to eliminate the danger, the first wave of soldiers that come in. And so you can associate an inflammation response. Think about, again, when you cut your skin, you usually get redness, you get swelling, there's heat, there's pain. That's actually your immune system doing its job. It's that first wave of soldiers that are coming in. And then what happens when the danger gets eliminated, the regulatory cells are starting to come in, and they're starting to initiate wound healing. So as I said, we have to repair the skin in this case for this example. And then all of those cells that came into the area, they leave the area, and you're just left again with the soldiers that are there to sound the alarm if they detect danger again. So that's like a normal immune response. So it's this balance of these effector cells, the first wave of soldiers that come in, and then the regulation that comes in the second wave. But in type 1 diabetes, we know through many different types of studies that there's a misbalance between the first wave of soldiers and the second wave of soldiers that come in. And so you're heavily weighted on these effector cells. They keep continuously destroying these insulin producing beta cells when they shouldn't be. And so we really want to understand this relationship and why we have this misbalance, and how can we use the regulatory cells to fix this balance and turn off those cells that are destroying the insulin producing beta cells. So that's the goal of my lab, is really to understand how these cells communicate to each other, why is there this misbalance, and how can we fix this misbalance by using cells that your body already has. So a natural biological cellular source that normally does its job of turning off those cells from destroying the insulin producing cells. So my lab for I've been at the DRI since 2006. So 16 years, my lab has really been focusing on understanding this relationship between these two types of soldiers. And what we know is, think about when you're in college, you have a bunch of roommates. Maybe you want a new roommate to come back to join the house. But really, to make the space in the house, you got to kick somebody out first. Well, it's the same thing if we want to think about giving patients more of these regulatory cells, because our body's in homeostasis. So we have to make this space for the new cells to go. So we got to evict some of those roommates that, maybe aren't contributing so much. They leave that little bit of milk in the bottom of the gallon. We want those roommates to leave, and we want the good roommates to come in. So that's how you can think of the immune system. So it's a house. There's only so many people that can be in the house at the same time. So if we want to invite new people in, we got to kick some of the old people out. So that's really what my lab has been trying to understand, is how can we make this space so we can give more of these regulatory cells. And more specifically, we want to give these regulatory T cells that are going to protect the insulin producing beta cells. So most of the time when you have danger that is detected by the immune system, it's a very specific response. So we know that the response that's killing the beta cells is a very specific response. So we know that the regulatory cells need to go to the beta cells and love up on those insulin producing cells and say, I want to protect you, from all this danger that's occurring. So that's what my lab has been studying. By understanding this environment, this relationship between these two types of cells, we've actually been very successful in using Treg cells as a therapy. So in my lab, we use a experimental mouse model. It's called the NOD mouse. It develops autoimmune diabetes, similar to how patients, it's spontaneous. This isn't drug induced or injury induced. It is destruction of the insulin producing beta cells that causes the diabetes in this mouse model. So we use this mouse model to ask biological questions that we can't ask the patients themselves. So we would love to be able to go into a patient's pancreas and specifically look at their islets and understand what's going on with the immune response. But of course, we need our pancreas to live. So we're not able to go in there and ask these types of questions in the patients themselves. So we have to rely on basic science research, like what goes on in my lab, to answer these biological questions. So the data that I'm going to show you today is all centered around using this T1D mouse model, again called the NOD mouse. So what we did here in this particular study, so thinking about the space, we got to eject some of the roommates out before we can invite new roommates in. So what we're going to do is we're going to make the space within the immune compartment, and we're going to give very specific Treg cells. So without going into a lot of detail, hopefully you can appreciate that we have mice that have recently become diabetic and we started our therapy. And what happens is when we give these Treg cells that go to the islets and they love up on the beta cells, we can 100% cure these mice of their diabetes. So if you see this line right here, we followed the mice for around 6 months after we started the therapy. You should know laboratory mice live to be about 2 years. So 6 months is quite a significant amount of time in the lifespan of this animal model. So you can see we followed the mice for up to 6 months. They didn't revert back to a diabetic state. This is exactly what we'd want to see in the patient population, where we cured them of their disease. And this is exactly what we did when we targeted the Treg cells to go to the islets and love up on those beta cells. And the one thing I want to point out here is other laboratories have used this mouse model, and they have been able to achieve some similar results, but they really had to use chronic treatments. So I just want to highlight this green box here. So we followed the mice for 6 months. These animals only received treatment for 17 days. And after 17 days, these animals never received any other additional treatment. So it's a very short treatment period. And then you can see during the follow-up, these mice remain diabetes free. And then the other thing that's going to be very important for the patients is we need patients to be able to respond to normal danger signals. You're going to catch a cold, you're going to cut your skin and get an infection. So we want type 1 patients to receive therapy to turn off that immune destruction going on to the beta cells, but we want them to be able to still respond normally to danger signals. So what we did is we took those mice that we cured of their diabetes and we challenged them with an immune response that should give some type of danger. So in this particular study, we put a transplant, and it was a skin transplant from one mouse to another mouse. So just like in people, if you receive an organ or cells from another person to yourself, your body sees that as not belonging to us and wants to reject it. And this is why transplant patients have to be on lifelong immunosuppression to turn off that response, because our immune system doesn't see that transplant as belonging to us, so it wants to get rid of it. So that's a very strong immune response. So what we did is we took the cured mice, we gave them a skin from a different mouse, and we should see that this recipient mouse rejects the new skin. And that's exactly what we're seeing here. We see a normal rejection, a normal immune response to these mice that we've cured their diabetes. And more importantly, we followed those mice for an additional 10 weeks. Again, a laboratory animal lives to be about 2 years, so that is still a significant amount of time for their lifespan. And when we monitor them for diabetes, they still remain diabetes free. So in this animal model, using this targeted Tregs, fixing that balance between the first wave of soldiers and the second wave of soldiers, we were actually able to cure the mice of their autoimmune diabetes with a very short course of immune therapy. So that's just when we want to assess autoimmunity and turn off that destruction of the insulin producing cells. But as Tom mentioned in the beginning, what happens to patients that have had their diabetes for a long time? How are we going to treat these patients? So we can use islet transplantation as a way of, again, giving a biological cure, replacing those insulin producing cells that have been destroyed by the patient's immune system. So when we think about islet transplantation into type 1 patients, they have poor glycemic control. And this type of transplantation has been proven to be very effective therapy. But like any other type of transplant situation, patients need to be on these anti-rejection medications, and they're required for life. And they have some risk associated with taking immunosuppressive drugs for the rest of your life. So therefore, there's only a relative benefit for islet transplantation is limited to only a select number of patients due to the fact that you have to be on this lifelong immunosuppression. So not only do islet transplant recipients need to overcome this rejection of their new islet cells, remember, they lost their initial islet cells because their immune system attacked and destroyed the insulin producing cells. So we also have to control this islet destructing response that's occurring in these patients in order to get lasting therapeutic success. So really, in the field of type 1 diabetes, there's an unmet need to develop immune strategies that will avoid the use of lifelong immunosuppressive drugs so that we can improve the safety and the efficacy of islet transplantation, and therefore making it much more widely available to type 1 patients to improve their glycemic control and diminish the burden of their disease. So we wanted to take this very successful therapy that we had, which we cured the mice of their autoimmune diabetes. What happens if we want to then give these animals an islet transplantation? So how we decided to approach it first is we didn't do islet transplantation. We went back to the skin transplant model to ask some questions about the Treg-based therapy. And so again, remember, if an NOD mice is getting a tissue from a different kind of mouse, your immune system sees that as not belonging to self and wants to reject it. So again, I want to highlight that these animals only got some type of treatment for a short period of time. In this instance, they got therapy up to 38 days. And then after that, these animals never received any additional treatments. So I want you to focus here on the blue line. So you can see when we don't give any type of therapy, this is what we normally see. We see these recipients reject this foreign skin, this transplanted skin. But when we apply our therapy, our Treg therapy, and we target it to the transplanted skin, we got 80% of the animals to accept this skin as almost their own skin. And again, we followed them up for 6 months. And so we were very happy with this type of response. Again, especially given that these animals didn't need lifelong immunosuppression in order to accept this foreign tissue. So this is the exact scenario that we want to see when we want to do islet transplantation. So that's kind of where I'm going to flip to the other project. But hopefully you guys understand this relationship between the first wave of soldiers and the second wave of soldiers, and how we're really utilizing the second wave of soldiers to come in to control all that destruction to the insulin producing beta cells. So the other project that I wanted to talk about is much closer to being applied to patients living with diabetes. And what we wanted to do was to test this drug called dimethyl fumarate. You'll hear me for the remainder of the talk refer to this drug as DMF. And we wanted to test it as a novel therapeutic agent for autoimmune diabetes. So this dimethyl fumarate, this DMF, it is an FDA-approved drug already. It was approved in 2013 for the treatment of relapsing remitting multiple sclerosis. So multiple sclerosis is another type of autoimmune disease, but in this autoimmune disease, it's actually the nerve cells that are getting destroyed by the immune system. So this drug already has a known safety profile for another autoimmune disease, and it's already an FDA-approved drug. So what we wanted to do is we wanted to repurpose this drug because it's already FDA approved. We could get it in the clinic much faster than if we tried to test a drug that wasn't FDA approved. So again, we went back to the NOD mouse model where mice get spontaneous autoimmune diabetes similar to the patients, and we treated the animals with this drug for 12 weeks, so for 3 months, and that's the blue line. And then the black line are the control or the placebo group. So you can see that we had around 70% of the mice that were diabetic. We did 12 weeks of treatment, and then we took the animals off the drug, and they didn't see any more drug after the 12-week treatment. And you can see we were able to get 70% of the animals to remain diabetes-free. So we went through this process of the best way of delivering this drug to the animals. And once we optimized this protocol, we were actually able to achieve 100% of the animals to reverse their diabetes when we treated the animals with the DMF compared to the placebo group. So this was for recently diabetic animals. And again, we didn't have to do a long-term or lifelong treatment in this type of setting. But we also wanted to test this drug in prevention. So we can also take these NOD mice before they develop diabetes, and we can apply this treatment and ask, did we prevent diabetes from occurring, from developing in these animals? So again, the blue line are the animals that were treated with the dimethyl fumarate, the DMF. The black line is the placebo group. And what we did is we started treating these animals when they were 10 weeks of age, which is before we start seeing diabetes onset in this model. And you can see in the placebo group, by 26 weeks of age, all of the mice had developed diabetes. where during the treatment period, while the animals were on the DMF treatment, we didn't have any of the mice develop diabetes. And then similar to the previous study, we took the animals off the drug, so they're no longer receiving DMF, and we wanted to see what happened to diabetes development when the animals were off the drug. So you can see that this blue line goes down over time, but still significantly different than what happened in the placebo group, where all of the animals developed diabetes by 26 weeks of age. So we followed these mice for up to the mice were a year of age, and we saw that around 50% of the mice, being 6 months off of drug, that some did develop diabetes over time. So as scientists, we love to run statistics and really try to find the significance of our data. So when we look at something called hazard ratio, which is just a way of assessing the placebo group to the treatment group, which in this case is the DMF. So we found that the DMF treatment at any time during the study period, those animals are 85% less likely to develop diabetes than our control group. So those are two pretty amazing results on this drug that's already being used in patients with another autoimmune disease. So we want to, at the DRI, we are planning on moving forward to bringing this as a clinical trial to patients. So that's kind of where this project is at this moment. I did want to just throw up this slide just to thank everybody that's contributed to the research that I'm showing to you today. And of course, I have to acknowledge our funding, and a lot of these studies are funded through our Diabetes Research Institute Foundation. So through donations, we're able to support new projects and also continue projects that have promise for the clinical setting. So I can't not thank the donors enough for contributing to the foundation, allowing us scientists to do some great work at the DRI. So I'll take any questions at this time. I'll stop sharing.
Okay.
And I'll happily take any questions from the audience.
Thank you, Doctor. We really appreciate everything that you brought tonight. And we are going to open the question and to remind everybody that the Institute is an 87,000 square foot building where all phases of research happen in one building. And that's one of the most amazing things and unique things about the Institute, as we continually work for the sustainability, the site, and the supply to make sure that all of those steps work in trying to find a cure for this disease. And I'd like to kick off with a question I had was, how far are you away, Dr. Baer, from that approach on trying to bring this to clinical trials? What's the next step for you to get there?
Yeah, so for the DMF project right now, the company that makes the drug is called Biogen. So we try to partner with Biogen to have them give us the drug for the trial, but like many companies, they didn't want to give us the drug for free. So we're trying to negotiate with them of trying to get, the drug is very expensive. So we've calculated to do the trial, just to obtain the drug to treat the patients in the clinical trial will cost around $3 million. So we have to, if the company's not willing to give us the drug, we have to, obtain the funds from someplace else. So I would say that is our biggest hurdle right now. But we have the NIH is very interested in this clinical trial. They're willing to work with us to get the drug at cost from Biogen, which will make it much more affordable to begin to think about being able to do this trial. So we are ready to do the trial. We have the data necessary that the FDA would want to see for us to be moving forward. So it's just really obtaining the funds right now to do the trial and submitting the application and getting the FDA approval and all of that red tape, I guess you could call it. But so we're ready to go. We just have basically, just as I said, we're trying to obtain funds in order to do the trial, mostly to pay, for the cost of the drug, because it's not cheap.
And do we assume that when this is proven to work, that when thousands and millions of patients can benefit from this, that cost of that drug will drop significantly to
I'll
be.
go up.
Yeah, I hope so. I mean, Biogen, like I said, this drug was approved in 2013. The drug name is called Tecofardia, and that came off patent in 2020. So they have like a brother drug where they changed it just ever so slightly. And so that new drug is called Vumerity. And so that's not on patent. So actually the Tecofardia version of that drug is now available in generic. So that is another option for the clinical trial, is we could consider using the generic form if getting the Tecofardia just is too expensive for us to do the trial, because we do want to move forward with the trial and not let that hold up if we don't have to.
Okay, Mitchell, you have a question?
Yes, thank you. Dr. Bayer, you really knew how to take very complicated concepts and make them very understandable.
Thank you.
Thank you, and thanks for all your hard work and dedication. Question: so in this clinical trial, are you going to use this drug along with transplanted islet cells, or is this with people that are on the verge of getting, or mice that are on the verge, or people on the verge of getting diabetes?
Yes, so the FDA for type 1 patients, the FDA, the population of type 1 patients that they love is the patients that have recently been diagnosed. These are the patients that are still in what we call the honeymoon phase. So those patients still have insulin producing beta cells. So there's still this destruction of the immune system that's going to continue to kill off those insulin producing cells. But we have found, especially in the mouse model study, that if you attack and stop that early enough, you actually still have enough residual beta cells left to kind of recover. So the FDA loves that population, and that's usually where they approve us to do clinical trials first, especially when we first do, that's usually a lot of safety involved. We're looking for efficacy, of course, but usually when we first do begin a trial, it's all about the safety to the patient, and then with efficacy also being looked at. So that's why they try to use that patient pool, because if we do have some success, those patients have some insulin producing cells left themselves. So you wouldn't need to replace the insulin producing cells at that point. Eventually, we do want to try this drug in the transplant setting. We haven't tried it yet to know if there's any benefit when we do islet transplantation, but it's definitely something that we're really interested in pursuing.
Dr. Bayer, we have a question that came in that asked if there are other research facilities around the world looking or using this drug, and if so, do we share this information so we can get two brains working on the same problem?
Yeah. So interestingly, my colleague who's an endocrinologist at the DRI, Dr. Vendrame, when we first started talking to the JDRF about giving us some funds to continue with our studies, they let us know that there was a group in Australia, in Melbourne, Australia, that they had done a small pilot study, that they had seen some data presented from this group. And so they said, why don't you touch base with the Australian group and see what they got and compare notes. So we did that, and the Australia group shared their data, we shared our data, and they only did what we call the diabetes reversal study, which is the animals developed diabetes and then they applied the drug. So they didn't treat the animals quite as long as we did. We did for 12 weeks. They only treated for 40 days. So they did a shorter period of time. So they had a little less efficacy than what we had, but they saw very similar results. So the JDRF love that, totally independent, not talking to each other, two different groups of scientists, got the same result. So they were very happy. They gave us some funds to kind of continue that line of investigation. So yes, one of the things that's really good about the DRI is we are open with our data, even with other scientists, because we don't want the egos to get in the way. We want to be able to help the patients. So we are very open with our data. Even with the Biogen company, we were sharing all of our data. We didn't make them sign a non-disclosure, none of that. We just want, here's this great preclinical data that we're getting. We're really interested in your drug. So we were even very open with the pharmaceutical company about what results we were getting in our preclinical studies.
Thank you.
Mhm.
Does anyone else have a question? Please feel free to chime in. Make sure you take yourself off mute if you want to talk. Bob, you gonna question?
Yes, trying to get it off mute. Excellent job, Dr. Baer. First time listening to you and trying to understand some of the things that DRI is doing. Very impressed, and thank you for your explanation, which was great. Between the two areas of study, the balancing of the effector cells and this drug, is there a particular area where that will be the study that we will concentrate on more than the other?
So obviously with the DMF, it's already an FDA approved drug. So that one's definitely much closer to actually helping patients. The antigen specific targeted Treg therapy, the first project I talked about, there are a lot of labs working on regulatory T cells as a cellular therapy for type 1 diabetes, and also in different types of transplant models, just not for islet transplantation, but solid organ transplantation. So there is, I would say around 2018, we started seeing pharmaceutical companies, biotech companies popping up. And I do believe there's around 7 or 8 now. And they're all focused on making what we call engineered Tregs. So like I said, we can't just give a whole bunch of just random regulatory cells. We really have to target the cells either to the insulin producing cells, or in the transplant, you would be targeting them to either the transplanted cells or the tissue. So these companies are really investing a lot of money of how can we make the right kind of Treg cells for the clinical setting. So the one thing that my studies has shown versus others is we really have to prep the environment. We have to make this very supportive environment for these regulatory T cells. We need them to go where they need to do their job, which in the case of type 1 diabetes is to the pancreas and love up on the beta cells. So we have to have a very targeted Treg population. So there are many companies that are working on this for the clinical situation. But my studies show that before you give Tregs, you have to set up this very supportive, loving environment for the Tregs. If you don't do that first, then the therapy fails. So we're a lot closer to using Tregs as a clinical approach, I would say, than we were 5 years ago. So now we understand what kind of environment do we need to make for these Treg cells, and then we just need the technology to catch up to make the Tregs that we need. So there's a lot of people working on that, and I really think in the next 2 to 3 years, we're going to start seeing some of these companies coming out with their approaches, and then us being able to test which strategy may be better versus others. So I really think so. That's like 2 to 3 year window. And then once we identify that, then I think we'll be ready for the clinical, to do a clinical trial. So that's farther away, but we're actually a lot closer than we were a couple of years ago.
Okay, thank you very much.
Mhm.
One other quick follow-up is with the other drug therapy, since it's already approved by the FDA, you're starting to do some clinical trials, or you're getting there. what is the time frame? Is it the same time frame as far as trials and safety and efficacy phases?
Yeah,
And
so
a drug that, as a drug that's already approved by the FDA, or is it?
Yeah, so
any
it makes it a little bit easier to get through the FDA since it's already approved and it's already used for another autoimmune disease. And so it already has a known safety profile. So that definitely speeds the process along. I would say we're hoping by the end of 2023 to be able to have the funds all set up and to start the trial. We are submitting my coworker, my colleague, Dr. Vendrame, in January, we're going to be submitting a grant to the NIH, and it's a preparatory grant. So it's to get all the paperwork, start submitting it to the FDA, start acquiring the drug. So that way we're all ready. We have all our ducks in a row to actually begin a clinical trial. So we're kind of in that phase. Hopefully we could do that in 2023, get that all lined up. The trial itself is we would treat patients for 6 months and then do follow-up for 6 months. So the trial itself would be 1 year in length before we would actually have the results from the study. So hopefully by the end of 2024, we would see some very good efficacy, and then we could open it up to much bigger, like a phase 3 trial where we could treat many more patients.
Oh, very exciting. Thank you.
Yeah,
Thank you for all your hard work. Really exciting.
Thank you.
Do you anticipate any side effects from this drug?
So far with the MS patients, of course, MS and diabetes aren't exactly the same disease. So that's one reason why we have to pay a lot of attention to the safety aspects when we initiate a trial. But really, this drug is very, very safe. They have very few adverse effects in the MS patients, and they've been taking, some patients have already been on the drug almost 10 years. And they take it chronically. They take it twice per day, every day. So it's already a chronic treatment. I mean, type 1 patients, as you know, you take your insulin injections every day. So I don't know, popping a pill a couple times a day versus, insulin every day, I'm not sure if that's much better, but, we would hope that patients, they would have just much better control of their disease and less complications, and their quality of life would just greatly increase, despite the fact that they, may still need to take, a pill every day, or two, a couple of pills a day, like the MS patients. That's how the MS patients take it.
And what's really becoming a very interesting thing on the research of diabetes is this phrase "in range," meaning that your blood glucose is in range, which I take it this medication will do. So even anybody who's using insulin knows what a balance it is and how challenging it is, which is why pump companies and CGM companies are doing so well. So the fact that these meds would keep you within that range a lot I would think automatically make it better than,
Yeah, and like I said, the first pool of patients the FDA would approve us to test first would be like I said, the recently diagnosed patients. But then after that, we can think about treating as a prevention. Like I said, we haven't tried in the transplant scenario yet to know if there's any efficacy. So, patients that would have, their disease, long-standing disease, we don't know yet if we would be able to benefit with the islet transplant with that drug yet, but definitely the recently diabetics, and also maybe as a prevention that worked very well in our NOD mouse model, was very good at prevention.
And again,
so that would be
this is one scientific area we're working in. There are many more within the DRI, and some of those deal with people where Bob would like to see.
Yes. Well, that's where the
we could use
antigen
now.
specific, that's where the Treg therapy would come into play. Patients that could receive an islet transplant or even a pancreas kidney transplant, you could apply this Treg therapy for patients, longstanding patients. We just don't know yet about the DMF, but it may be very effective there as well. But then in a few years, you have to wait for the Tregs to come into play. But And there's already been clinical trials with just Tregs. There's just been clinical trials with just immune modulation. What my work does is combine the two together, and then that's the magic bullet. So those two scenarios have already been tested in type 1 patients in other clinical trials. So once we had the right kind of Tregs, I think we would be able to move fairly quickly into the clinical trials of combining these together. Because
And
they
the science
separately,
will-
yeah,
they're moving away more and more, or there are more people searching for a substitution for cadaver donated islet cells that they can be synthetically created. In fact, there are some people stating that we're very close to that. So I
yes,
think that would also help the process as
right. The
well.
Vertex trial is going very well. We look at stem cells at the institution, so we're also involved in that kind of research, as well as finding an alternative source for the insulin producing beta cells. So that would be more for the long-standing patients to think about getting a transplant.
I didn't forget you, Bob.
Thanks, Tom.
Any other questions?
I just have a comment about this drug company that's so myopic with multiple sclerosis, but not seeing the vast amount of money that they could make
Yeah,
if
the
they,
marketplace, I mean,
it's kind of
It's
mind-boggling.
I don't understand the thinking of drug companies. I'm a
Do they have a-
scientist.
do
I
they-
want a better humanity. I do have to say Biogen is a company that's largely focused on neurological diseases. So MS, which attacks the
Right,
nerves,
right.
Parkinson's disease, Alzheimer's. So diabetes is definitely out of their wheelhouse. It's
Yeah, but-
not, metabolic diseases is not something that they invest funds in. And I guess when you have a $9 billion drug and another patient pool is going to use it, there's some risk that if there was adverse effects, that maybe something would happen, for the MS patients. I mean, I'm not sure. I don't know who gets it. It was a 2-year process. I'm sure the attorneys go in and do the risk assessment. And like I said, I'm not sure how it all works, but I mean, we can still obtain the drug. It's expensive. So that just slows everything down, right? Because we have to find the funds someplace to, pay for the drug. So it's frustrating as a scientist, it's frustrating as the patients to know that there's a potential therapy and we have to wait because we can't afford the drug to do the trial yet. It's frustrating for us, don't worry, just as much it is for the patients themselves.
Anyone else? Calling once, twice. Well, as always, Dr. Berry, you've always been extremely informative. Heather, did you have a question?
Oh, sorry. Yeah, I was just gonna ask really quick about the Treg therapy. Was that an option for longer standing patients, or is that?
Yes,
Okay.
so since patients that have had their disease for quite a length period of time, not all your insulin producing beta cells are gone, but there's not enough to
Okay.
control the insulin, the requirements for controlling your blood glucose. So there you would have to receive some type of transplant. So there we did find very good efficacy with the Tregs. So that would be the type of therapy we would want to be targeting for patients that have longstanding disease.
Okay, great. And I was just curious, you talked about getting the right environment for the Tregs. I was wondering if you could describe that a little bit. I was curious about that.
Yeah, so I like to use the example, we're in Miami, we have the beach, beautiful waters. You can decide for the day you're going to go to the beach and you get your swimsuit on, your suntan lotion on, you get some music. I like country music. You bring, whatever you guys like. You go to the beach, you have everything you need to go enjoy the day, get a tan. But now you go and it's cloudy. It's nighttime. So the environment is not conducive for you to get your job done, to do your task. You have all the right machinery. You're there, right? But you can't do your job. It's the same for these regulatory T cells. If we don't make this supportive environment, they can't do their job. So my lab for the last 16 years have been asking the biological question, what does that environment look like? So there's many labs that are working with Tregs. They will take them out of the body and expand them in a culture dish and then want to give them back. But again, if you don't make the supportive environment, we can give as many of these cells that we want, but they're not able to do the job. So that's really where my research has, I think, flipped the field, thinking that we can't just give a lot more of these cells and think it's going to fix the problem. We have to make the right environment for these Treg cells to do the job, to fix that misbalance. Did that make
Okay.
sense?
Yeah, that makes sense. Yeah,
Okay.
thank you. And thank you for everything that you do.
Thank you.
Again, I'd like to encourage everyone to go to diabetesresearch.org, become a DRI insider, so you can be kept up to date on what's happening and when. And I just want to give one final call. If anybody does have a question, I don't want to hang up and somebody go, I meant to ask. So if anyone has a question, otherwise, again, tonight I'm wearing blue. Blue is the color for diabetes awareness. So make sure you wear it sometime during the month. And thank you again for all of your support. If you don't do what you do, Dr. Bear and the rest of the scientists can't do what they do. So we certainly thank you all for coming. We thank you, Dr. Bear, for being here. And again, thank you for your support, continued support, and we'll see you again on the next Meet the Scientist. Have a great night.
Thank you. Enjoy your night.